don't have to do. So most importantly, just listen how the students are present in the case, what are the questions commonly being asked, and you will get the recording and you will get the PPT. So don't waste your time writing down, taking screenshots, all those things. Do not waste your time. Please have a water bottle or keep snacks next to you because it'll be a marathon session. 6:10 to 6:15 you're going to start. I think till 8:15, 8:30 it will go. In case you want a break in between after any system, please put it in the chat box, okay? And if you have any doubts or any questions, you always write it down on a piece of paper, whatever. And at the end of the class, you can send it in WhatsApp. I'll try to clear the doubts as much as possible. I've renamed the volunteer's name so nobody will know who is answering. When I call out your name, just you have to unmute and start answering, okay? We'll start, will not waste time. So this is like for the newcomers who have not attended the previous class. So you don't have to carry your logbook or your thesis for your DNB exam. They're not asking, but at least for MD exams, they're asking. It again depends on the examiner, but 101% they will ask the hard copy of a thesis, and few exams are very fond of checking a logbook. In case you're not on logbook, get it written by juniors or write if you have time. So don't waste your time writing logbook now at the last moment, especially MD candidates. If you are juniors, then write it or tell them to write and keep it ready, your logbook and a hard copy of your thesis. DNB students, you have your practical on May 26, you don't have to get a logbook or thesis. It is just your steel scale, neat apron, a magnifying glass. I don't think you will have time for magnifying glass because it'll be very fast, especially for short case and long case. Long case, so they will not give time even for short case, like lightning speed they'll do. Only 5 minutes is given for short case, and carry this extender pointer, okay? In case I'm not audible or some network issue, please put it in the chat box because I won't be knowing sometimes there is a network issue or my voice is not audible or whatever, okay? So all the best. Candidate May01, are you there? You can unmute and we'll go for the first case. Are you there, May01?
Yes, sir.
Okay, first tell me what study is this?
IVP, intravenous pyelogram.
Don't say pyelogram.
Yeah.
So it is the intravenous urogram. What are the findings you're seeing over here quickly?
Bilateral ureters are deviated, sir, and bladder is conical in shape,
okay.
Due to extrinsic mass effect likely.
Okay. What is the provisional diagnosis? Your first is, imagine this is, you're a DNB candidate. So imagine if there's a OSCE, the first question will be, what is the procedure name? The procedure name is, do not write abbreviation. Intravenous urography or urogram completely you have to mention. Next, what is the findings? Second question will be, what is the findings? As you mentioned, the ureters are widely placed and the bladder is like cone shaped, a pine shaped, or a Christmas tree. You can write those appearance, nothing wrong with it. And then, what is the diagnosis? What is the diagnosis you're going to write for this?
Pelvic lipomatosis. Sir.
Yes, that is the correct answer. What is the DD you're going to write for this?
Any pelvic hematoma in case of trauma?
There is no trauma, it's nothing. Why will a trauma cause so much of deviation of the bladders and like conical shape of the urinary bladder? Are there any mass you can think? Some ovarian mass, yeah, lymphoma or like a bilateral ovarian mass, like a bilateral ovarian tumors. Not that classical over here, one of the DD, but you should know at least 2 DDs for this. So this is the one, and go to this. This is the same patient. They're done. What is the study name?
Double contrast barium enema, sir.
Very good. There's a double contrast barium enema. That is the correct procedure done. So what is the diagnosis? Diagnosis already told. Forget the diagnosis. Tell me the findings. Quick.
The rectum is narrowed and reduced, shows reduced caliber. Sigmoid colon shows loss of postural pattern.
Okay. Sigmoid colon usually not have so much hosta. It will mean the cecum will have a lot of hostration rather than sigmoid when you compare. Okay.
Okay.
So there's like, you can just mention diffuse narrowing without any irregularity in the mucosa. That is more important. There's narrowing, but there's no irregularity noted in the mucosal lining of the rectum as well as the sigmoid colon. It looks more of an extrinsic compression rather than a malignancy. If it was like an apple core sign where a suspect of colorectal carcinoma or something like that, it will be like a diffuse circumferential irregular narrowing with mucosal irregularities. These are 2 important wordings you need to mention. Am I clear?
Okay.
Now the same patient, I'll provide the CT image. So what's happened in CT? You can see. Describe it quickly.
Axial CT section shows mesenteric fat stranding, mild mesenteric fat stanting in the perivesical region with increased
Okay.
with
What
fat
is happening soft tissue?
proliferation.
Comment about the soft tissue or the fat density lesion.
Okay. There is hypodense lesion with
Just
surrounding.
probably is not a urinary bladder, something they've shown. So this is a diffuse hypodense lesion noted in the peritoneal cavity with the adjacent to the mesentery. So as compared to the previous image, they would have definitely they will give you all three in one image, in one slide. This IVU image, this barium double count with barium minima, and the CT image, and then ask for a diagnosis. This kept in different. If at all, if this case is given as a short case, you have to be quick enough to answer. Okay.
Okay.
So they won't give only one image like this. It will be a completely CT film image. Okay. So you have to be quick enough. This will always be kept as a short case. Pelvic lipometers or anything related to urinary bladder genital system will usually be a short case. They won't keep this as a long case. Okay. So what is the treatment for this? If it is OSCE, last option will be prognosis or a treatment or the management. One line about it.
Asymptomatic conservative management.
Correct. If the patient has more symptoms or like what do you call like increased micturition or frequency of all those things, then you have to manage surgically. We have to resect the lipoma. There is a intervention required for that. Okay. Nothing much on it. I've given the important clues and all. What you need to know about pelvic lipomas is go through it when you get the PPT. You too, Mike. You need to be fast. Candidate number ME002. Candidate number ME02. I will ask you to unmute. Yeah.
Yes, sir.
First image. What is this radiograph? First, just read the radiograph quickly. We have less time today. You have to be fast and quick. If you don't know, you have to directly say, I don't know, or pass. Okay. First radiograph, I want to read the radiograph for this.
Zoomed out frontal radiograph of the abdomen.
Okay.
Hello, sir.
Yeah, you're audible. Go ahead.
Yes, sir.
It's a frontal radiograph of the abdomen. It's a spot magnified image of the right iliac fossa or right lumbar region. Showing what is it showing? Tell directly the pathology.
Emphysematous pyelonephritis, sir.
Yeah, that is a diagnosis, correct? But I want you to read the film. You mean sometimes in short cases they'll ask you to read the film.
Okay, sir. Radiolucency is seen around the renal right renal
kidney. Nothing wrong. It's almost correct. There is a lucency noted across the right renal parenchyma. The corresponding CT image axial. What does it show? What is happening?
It's showing lucency around the.
No. Do not use the word lucency on a CT. This is a CT image you're saying. When a CT, lucency is used only for a CT image. In CT image, what is happening here?
Air is in the renal cortical and the medullary region.
Yeah, you're going to say this. You're seeing the axial CT image of the abdomen at the level of the right renal kidney, where the parenchymal destruction is noted and is completely being replaced by the air. It is replaced by the air, and there's destruction of the parenchyma. So in the below next image also, you're seeing the parenchyma is being replaced by air. So this is a classical case of emphysematous pyelonephritis. This is one case, or sometimes in a. One second, my voice is breaking. They're saying I'll just check the net connection. 1 second. Just for
recording in progress.
Am I audible? Is my voice clear now?
Yes, sir.
Yeah, okay, we'll go ahead. So this is an important case. It will usually be kept as a short case. Many examiners have got this collection. Emphysematous pyelonephritis is the most commonest condition which the examiners have got in the collection, which you need to know. Okay, and they will ask the causes. What are the causes of emphysematous pyelonephritis? And sometimes in radiography I can check is something grading or seeing something that it is not important to know because there are two types. So much in depth they won't ask. Main thing is how do you manage emphysematous pyelonephritis? What is the diagnostic criteria? Whether only the renal parenchyma is involved or the air, whatever the air is going to the retroperitoneal space is also there that you have to look. Other than these things, management, like as an important diabetic or what condition, septicemia, you have to know. Okay. Candidate number May 03.
Yes, sir.
It's a simple case. First, you don't have to tell a diagnosis for me. First, identify all the sequences for me.
So the first one is CT.
Very good.
Second is T2 image.
Okay.
Third is T1 image.
Correct. This is post
And
contrast.
this is contrast T1 image.
Very good. So it's a simple, straightforward case. This can only be as a short case. Never they'll keep this as a long case. OSCE they might keep sometimes. They might ask you for DEDs, all those things. Now tell me the diagnosis quickly. These are simple cases. That's why we'll not waste time for this. Diagnosis directly.
So it is a polyp inside the bladder.
Okay, it might be a polyp one thing, but usually very rarely we see polyps in a urinary bladder. So polyps are commonly seen in case of a gallbladder or other locations like a colon, all those things. So this is a lesion. Now describe the lesion quickly for me. How it is appearing in CT?
It is a well circumscribed lesion which is hyperdense on CT.
Very good.
And
Wait. Don't be in a hurry. Don't be in a hurry. Why are you saying hyperdense? It is a post-contrast CT, na? You can see the contrast and vessels, yes or no?
yes, sir, post contrast CT. So it is showing contrast enhancement on CT image, and also on MRI image we can see mild contrast enhancement. It is hypointense on T1 and T2 image.
Fine.
So the differential is going to be TCC of urinary bladder.
Correct. So TCC of urinary bladder will be your first diagnosis always. Polyp will always be a DD. Do not say polyp in urinary bladder. Rarely we see urinary bladder polyps. Yes, it will be a DD, but most common will be a transient cell carcinoma. Very rarely they'll ask about the TNM staging of TCC and all. Very rarely. But you have to know at least TCC for a short case. We'll go to the next case. You can mute your mic. I've given all the important clue points which you need to know. Regarding cystoscopy, what will be the findings, other bladder tumors, and what are the lymph nodal things involvement in to check if you to get this as a short case. Candidate number May 04. I think it will be tough for you. I'll come back to it later on May 04. You can mute your mic 1 minute. I'll come to May 07. May 07. Are you there? Quick.
Yes, sir.
Yeah. What is happening?
Sir, there is evidence of a well-defined large abdominal mass located predominantly in the left side of the abdomen.
Okay.
The lesion appears heterogeneous, showing few areas, showing heterogeneous contrast enhancement, and also showing few hyperdense areas, likely appearing fatty density. So.
Correct. Go ahead. Continue. Quick.
Then, so the lesion, the lesion is seen to
epicenter of the lesion. I want the epicenter of the lesion. Where exactly or where probably it is arising from? Intraperitoneum, retroperitoneum, where exactly? What do you think?
Sir, it is seen to, sir, in the retroperitoneum.
Very good. It is retroperitoneum stage. Why retroperitoneum?
Yes,
see the kidney, the left kidney.
Yes, sir. It has been displaced.
Very good. So the epicenter of the lesion, it is a large, well-defined, a heterogeneous lesion with few fat components within. Predominantly appears more of like a soft tissue density lesion with fat components within. Correct?
Yes, sir. So the lesion is. So there are few areas of most likely calcification seen in the periphery of the lesions in the third slide. So.
Fine. Correct. Diagnosis, what you want to make. Do not waste time. These are like simple, straightforward case. I'm rushing. Why? Because this is straightforward, short case or OSCE. They will never come for long case.
Liposarcoma.
Correct. So you have to write a complete diagnosis. Retroperitoneal
liposarcoma.
Do not just write liposarcoma. Okay. In case if they ask DD, what would you write for retroperitoneal liposarcoma? Large exophytic renal angiomyolipoma also. Very rare. Very rare. Why? Because of a fat component and a large heterogeneous fat density. More importantly, it is adjacent to the left kidney. Like retroperitoneal means it is posterior to the left kidney. So it can be a possibility if at all they ask you DD in OSCE. Remember 3 things. When you prepare for OSCE, always you have to know the diagnosis. That question will be the diagnosis. Second will be DD. Third will be treatment or further management. any disease, any case when you're studying in for the next 10 days. These three things you have to remember. Okay?
Yes.
Mute your mic. I've given all the key proof points. You can go to, including DDs, management, everything I've written. Okay? Don't waste your time. Mute your mic. I've given the key points also, including management, everything I've written. Okay? Candidate number Me09.
Hello. Yes, sir. Hello.
Yeah.
So I have been provided with the axial and coronal images of the CT scan.
Very good.
Which shows there is a well-defined exophatic mass lesion, well-defined heterogeneously hypotense mass lesion, likely arising from the lower pole of the left kidney, shows a peaking sign. Along with that, it has a central non-enhancing area like necrosis, likely arising from the left renal cell neoplastic lesion like RCC arising from left lower pole.
Very good. Excellent. Simple, straightforward. It's a don't have like DDs at all for this type of case. It's a straightforward renal cell carcinoma case. You will never make a blunder in exam saying neuroblastoma for all these things at all. Am I clear? Now the next thing is I've given the slides over here related to difference between WIMS and neuroblastoma, all those things. But they will ask 3 points. If you get this short case, tell me 3 differentiating points between WIMS and neuroblastoma. Quick.
Calcification more in.
Wait. Don't be in a hurry. Always start with age. Always start with age.
Earlier age up to the 1 year, 2 year, average 1 or 2 year in the neuroblastoma.
Simple. Very simple thing I'll teach you. First alphabet is N, neuroblastoma. So it will come first, less than 2 years age. After it, whatever it comes, W comes later on. So it is later age, it is 4 years. So age over. Next criteria is calcification, 100% correct. So 90% calcified neuroblastoma, less than 10% calcified WIMS. 2 points over. Next 2 points I wanted to tell quick.
Vessel encasement and vessel displacement and crossing midline, not
yeah.
crossing midline.
Wait. Which will cross midline? Which will not cross midline?
Neuroblastoma will cross the midline, WIMS will not cross the midline.
Okay, that is okay. That's also an important one. One more. Last point to tell about metastasis. Which lesion will cause where the mets?
Neuroblastoma will skull mets, while the WIMS have the chest, the lung mets.
Yeah, neuroblastoma will be bone or skull mets, whereas the WIMS will be lung metastasis. Okay, that is more common. And important point you can see there. You can see, as you said, calyces are all distorted in case of a WIMS tumor, whereas a neuroblastoma there will be no distortion of the WIMS. In a neuroblastoma there won't be any calyceal distortion. I've given the differentiation points. This you have to know because out of 4 short cases, 1 short case will be from genital nerve system, and they will keep this one case. Okay, you can mute your mic. I've given all the key points. You can go through. I will put the differentiating points. I have put 10. At least 3 to 5 you have to know. Do not by heart. My sincere request, don't by heart and go to exam. You'll make a blunder. Understand the concepts. Which will come first in the age, which will come later in the age, which will calcify, which will encase and lift the vessel, which will invade the vessel. Just understand the concept. You have to remember this whole lifetime. You will be seeing a case of renal cell carcinoma in your day-to-day practice also, as well as when you become a consultant. So that time at least you should be knowing these things. Okay. I'll come to candidate number Me08. It's a simple case.
Yes, sir. It's axial, multiple sections of axial CT cuts with contrast. So in the right kidney, in the upper pole, I can see there's a heterogeneous lesion with central non-enhancing areas, and also the lesion is extending into the right renal vein, which shows the enhancement and also expansion of the right renal vein and also the suprahepatic segment of IVC.
Okay.
So given this, the most common differential would be a renal cell carcinoma.
Okay. It's a simple case. I have not made hi-fi things so because every exam will have this as a short case in the collection. Only thing I wanted when you go back to read, please read about MRI also. I have given the key points. What will be the MR imaging for a renal cell carcinoma? They are asking the sequences which is done in your department. What is the protocol for a renal cell carcinoma? And you give contrast, you don't give contrast. If this patient, imagine the urea creatinine elevated, what would you do? So then obviously we have to do MRI rather than doing CT because it will not be conclusive. We have diffusion weighted imaging, other imaging so to make a diagnosis. So read little bit renal cell carcinoma. It will be a stock question. Okay.
Yes, sir. Thank you, sir.
You can mute your mic. Quick, we'll go to the next case. It's a simple one. I want Me04. to unmute your mic and quickly tell what is the imaging given to you. Quick.
Sir, I have been provided with CT axial sections.
Very good.
Post-contrast imaging.
Okay, correct. Good.
And there's evidence of a hyperdense
correct.
So the
go ahead. Calculus
hyperdense calculus.
Yeah, where it is noted.
Sir, at the renal hilum noted of the left kidney.
Okay.
The kidneys are the left kidney is grossly enlarged, showing multiple cystic spaces, which
don't say cystic spaces; it becomes dilatation calyces. If you say cystic space, it becomes a completely different diagnosis. So first, tell me diagnosis, then you can describe what is the diagnosis.
So it's likely staghorn. This thing, xanthogranulomatous.
Pyelonephritis. Completely. Don't stop only at xanthogranulomatous. Xanthogranulomatous pyelonephritis. Okay. What is the sign? What is the name sign they usually use for xanthogranulomatous?
Bare paw sign, sir.
That's it. So why I kept this? Because this usually will be like a spotter or a OSCE. If you're giving MD exam, this will usually be kept as a spotter. So you need to write completely. Don't write XGP and all abbreviation. Xanthogranulomatous pyelonephritis completely need to write. Sometimes if it is an OSCE, the last diagnosis, name the sign appearing over. What is the management? Okay, you can mute your mic. I'll go to next candidate. Candidate number May 05. Candidate number May 05. Are you there? Quick.
Hello, sir.
Yeah.
Yes.
What are the images you're seeing? First image. What is the first image you're seeing?
Non-contrast axial CT image.
Good, good. This is a post-contrast. And this I've given Hounsfield, it's a fat attenuation link. This is a fat attenuation, and there's a calcification and the fat, and this is a post-processed image. Okay, you can see a VRT. It's a volume reading technique, correct? So you have seen the plane. Don't use the word plane. Use the word non-contrast, contrast, and the magnified post-contrast. So what is the diagnosis? This is not a routine case. Usually you don't see this type of case. I'll give a simple clue. If at all you're seeing a fat density with the calcification in a female patient in the pelvic region. So what is the diagnosis you want to think? Near the ovary or whatever?
Dermoid.
Okay. Similar thing or a teratoma, you apply the same thing.
Teratoma.
So this is a intrarenal teratoma. Now quickly tell the findings. If at all if the exam asks you to read the image, what would you, how would you read? Quick.
Isodense lesion showing no enhancement with calculus and no evidence of vascularity.
Don't tell calculus. Calcification and
with calcification and fat attenuation areas.
Okay.
And no evidence of vascularity to the lesion.
Very good. That is the most important one. That is given you the volume reading image. Okay. There is no vascularity, no enhancement. Correct. Will not waste time. It's a simple case.
Benign.
It's a benign condition. It's a ovarian teratoma. Okay. It's not ovarian. It's an intrarenal teratoma. Okay. I've given the key points which you need to know. Okay. Mute your mic. Candidate number May 06. This is not a routine case. That is why I kept this case. At least I want to tell the findings. What are the findings you're seeing? What is the first image?
Sir, this is non-contrast.
Correct. This is a non-contrast. And then you have the contrast images.
Contrast enhanced.
Directly tell the pathology. Where exactly you're seeing the pathology?
So around the kidneys means perirenal regions.
Yeah, perirenal region and bilateral, both the sides.
Bilateral, yes.
Very good. Describe the lesion for me.
Sir, isodense lesion. Isodense, there are well defined isodense regions have seen in the bilateral perirenal regions.
Very good.
Which shows no enhancement on the contrast.
Correct. There is no enhancement. Continue.
The lesions show no invasion into the kidneys.
Very good.
Kidneys or adjacent organs.
Very good.
And pattern between the liver and kidneys is well maintained.
Yes, this is how you're going to tell in the exam, and you have to be a little more louder and clear. Do not stammer.
Okay.
Correct regarding the what is the borders, the margins of the lesion, how it is appearing, there is isodense or hypodense, and then what is the lesion, appearing on post-contrast, whether it's enhancing, non-enhancing, is it invading the adjacent renal parenchyma, other organs, or what is it causing, like mass effect or anything like that. So all the 5 points are told. What are DDs or a diagnosis you want to tell for this type of lesion?
Renal lymphoma.
Lymphoma is the most common DD, but lymphoma usually will enhance. It will not be like a isodense or a hypodense lesion, both in a contrast and a non-contrast CT. Lymphoma is one of the DD. Other than lymphoma, it is a similar sister concern lesion of a lymphoma. It's again starts with L only. So renal starts with L. I have not seen this case.
Lipoma.
Not lipoma.
No, not lipoma. No.
Why will lipoma like bilateral symmetric
no,
like
no,
this?
No. Sorry. No.
So this was a case of a
leukemia.
Not leukemia. It was a case of renal lymphangiomatosis. Read about it. Sometimes they keep some bounces like this so that you don't get the diagnosis correctly. Something. So given the important points, the DDs for lymphangiomatosis, how to differentiate, what is the cause for lymphangiomatosis? All the things are given the key points. So this will be like kept a short case. Sometimes they might keep. You should be aware of the entity like this. Okay. Can mute your mic. I've given the key points. You can go through it. Candidate number May 10, May 10. Candidate number May 10. Are they quick?
Yes, sir.
Yeah.
There is a.
Go ahead. What are the images given to you? Quick.
Axial non-contrast CT, and then section of CT post-contrast. Then there's a SAT section post-contrast.
Very good.
There's a well-defined cystic lesion with wall calcification and heterogeneous density.
Not heterogeneous. Why you want to tell heterogeneous? So uniform like isodense.
Mixed density.
Yeah, you can tell mixed density lesion with peripheral calcification with multiple cystic lesions within this lesion is noted. Post contrast, what is happening?
The wall is enhancing.
Very good. Septa is also enhancing if you see as compared to this.
Yes.
It's a simple, straightforward case. So, what is the diagnosis?
So this can be a hydatid cyst.
Yes, because the given history, Middle East, all those things are given. So the question is, so you made a diagnosis. Diagnosis is correct. Now tell me the DD for this.
Cystic renal cell carcinoma.
Cystic renal cell carcinoma will be a third DD. Cystic nephroma will be a first DD. Okay. Hydrated cystic nephroma, cystic RCC. Like this order you're going to tell. Next question is, will you do a biopsy of this? Yes or no?
So it's hydatid cyst will not do the biopsy.
Correct. Reason, the exam, they would ask, imagine this is a OSCE question. First question will be, what is the diagnosis? You're told correct, hydrated. DD, yes, 2 DDs are given. Cystic nephroma and cystic RCC. Third question is biopsy indicator or not? If not, why they'll ask? What will you tell? You said no, because I hydrated. The reason for no. If you do not tell, you don't worry.
So it can initiate allergic reaction within
correct.
the body.
Use the word anaphylactic. Use the word anaphylactic reaction. It is contraindicated because this might react. I mean, the patient will have anaphylactic reaction. Next, what is the treatment or what is the management of this hydrated patient?
So antihelmintic drugs, and this may require alcohol injection.
Yeah, that can be done. I'm not that much well versed with the alcohol injection, the intervention, or please read about it. But at least antihelmintics, you should know. Just ask your medicine friends what are the antihelmintics they give for hydrated. Okay, your description, diagnosis, DDs are correct. Okay, you can mute your mic. Candidate, I've given the key points, all the things I've mentioned. What will happen if you do a biopsy? It'll rupture and cause dissemination or anaphylaxis. Okay, I've given the important clues. What are the things for the hydrated? So, candidate number May 11. His name was Murara. He said, I'm not able to find it. If you're there, I want you to unmute or raise your hand so that I can unmute and you can answer this case. Quick. Murray is the name of the candidate who wanted to answer. If you're not there, I'll go back to May 01. Quick. There are plenty of cases. If I go at this speed, it will be till 10 o'clock, then I'll be discussing. So I'll go. Okay. Quick. So you're seeing this case. I've asked you to unmute. You can unmute and answer. Very good. First image. What is what are you seeing? First read the film for me. Don't tell the diagnosis. Diagnosis everyone will tell.
So this is a barium film, sir.
No. Why barium? This is not a barium. This is just a plain film.
Okay, sir.
This is what we call metallic screws or whatever.
Yes. In the plain abdominal radiograph, there is a curvilinear Lifshitz noted along the bladder, urinary bladder.
Okay. Corresponding CT image confirms the diagnosis. What's the diagnosis? Quick.
Emphysematous cystitis, sir.
Correct. Emphysematous cystitis is the correct diagnosis. Please do not make mistake when you're writing emphysematous spelling. I've seen many students making a mistake. Do not make mistake when you write emphysematous. Practice number 1. Second question. What are the cause for emphysematous cystitis? Quickly.
Diabetes.
Yeah, diabetes, that is the clinical, whatever causes. Tell me 2 bacteria or 2 microbes causing emphysematous cystitis.
Klebsiella and Proteus.
Correct. Klebsiella and one more is E. coli. Escherichia coli. Okay. Next, how is it managed further?
The management is... don't know, sir.
Don't worry. They have put it on high antibiotics. Sulbactam or tazobactam, that's what they're going to put. So, treat it conservatively. You don't require any surgical intervention. Okay. So, this is a simple case commonly asked in OSCE because they last time asked name the causative organism for emphysematous cystitis. You can mute your mic. Candidate number May 01. Quick. May 01. Quick. Study name.
What was the organism? Intravenous urography.
Good. What is happening? I've put the arrow marks over there. Exam don't expect arrow marks and all. They will not give any arrow marks. Questions will be asked directly. So first, this will be like this. So what would you? What is happening? Quickly. You can't waste time.
Lucency is noted in the left upper quadrant, sir.
Don't tell left upper quadrant all. There's something 9 quadrants in abdomen. You just can't blame it to left upper quadrant and all. Use the quadrant names. Hypochondrium or the epigastrium. Where exactly you're seeing? Or the left lumbar region or left iliac region. You have to use the names. Forget all those things. Forget all those things. Answer my question. You said intravenous urography, correct? What is happening on the right side?
There is mild mass effect on the calyces.
Nothing. That and all you forget. There is excretion of contrast there or not? That you answered.
Yes, sir. Excretion of contrast is there.
What is happening left? Excretion of contrast there or not?
No, sir.
Not there. Now tell me 2 conditions where you don't see excretion of contrast, but there is only dense nephrogram you're seeing, but you're not seeing excretion of contrast in the pelvic calyces system or the ureter. Clear?
Okay.
Now tell me 2 conditions where you don't see the contrast in the ureter or the calyces system.
In the case of
already it is dense nephrogram, it is concentrating, but is not coming to the pelvis or the ureter. Maybe it might be early film you need to tell because they're not mentioned how many minutes film or whatever. Correct?
Yes.
So conditions. Okay, I'll just give you CT image so that we can make the diagnosis much faster. Now seeing CT. Now tell what is the diagnosis?
PUJ obstruction.
Correct, no? So it is simple, straightforward when you see a CT, but we come for conventional imaging. Usually they won't give only 1 image, at least 2-3 images they'll give you. That is a 1 minute, 5 minute, 15 minute, 3 images will be there. So whenever you see any IVU or any conventional procedure, see to that you are seeing the contrast equally from both the kidneys, the calyces and the pelvis as well as ureter. If something is not happening on both the sides, it's not symmetrical, means you have to suspect some pathology. If you see the size of the renal shadows compared to right and left, this is like ballooning, it's like bulging. Are you able to see? Yes or no?
Yes, sir.
So there's a cortical thinning, the complete thinning. That is what the arrow marks are being pointed out. But it's difficult to the moment to see only this. You might ask for a second image or whatever, but you should be knowing it can be entity like a PUG obstruction or a chronic obstructive disease like this. Okay.
Okay.
So it's a late discovery. Not usually it will be commonly seen a neonate or a newborn. Okay. You can mute your mic. Candidate number Me07. We have discussed it last time this one. I wanted to identify quickly, tell the diagnosis, whether it's intraperitoneal or extraperitoneal bladder rupture. Candidate number Me07, are you there?
Yes, sir. Sir, intraperitoneal.
Don't be in a hurry. See correctly. What are the signs? You tell me 2 differentiating points between intraperitoneal and extraperitoneal bladder rupture. First,
Sir,
wait. What study is this?
Sir, it's voiding cystogram, sir.
Okay, because you can see the catheter here. So they put the contrast and I asked the patient to void. Okay, and there is extraversion of contrast. Once there is extraversion of contrast, you need to look for two important points. Whether it is contrast is coming into the peritoneum cavity or retroperitoneal cavity, correct? So I'll give you, before this, I'll go back to this image, the same patient. This is the same patient. So what would be a diagnosis now?
Sir, here it is within the pelvis extraperitoneal, sir.
100% correct. It's extraperitoneal rupture. Why? Because it has thin, streaky contrast, not only in the pelvis, going more towards the thigh region, and maybe most commonly there's rupture of the tomb of the diaphragm of the urinary bladder.
There was one, like in the previous image, I can see the Foley's bulb down. So I thought maybe that is the bladder and the upward is the contrast which is going. So that is what
thin, sticky contrast. Don't worry. The thin, I'll show you both. That is why I called you, because I'll show both the cases. Now you've seen this is a extraperitoneal rupture. You can see the contrast, thin, sticky contrast outside the bladder. Actually, this is not a gold standard image. They have to give the complete abdomen image, including both the right iliac fossa. Now I've given the clue points, important differentials, how to diagnose a cystogram, how to diagnose CT cystogram are given. Now see this key points and all I've given. Go to and see this case now.
Yes, sir.
This history of trauma I've given. Now where is the contrast going?
The intraperitoneal, it's lying in the bubble. It's lying in the bubble, sir, and going to the peritoneal cavity.
Yes, this is the two important golden points you need to identify. Where an intra and extraperitoneal. Intra, it will line the bowel loops and it will go into the peritoneum. Okay, this is a case of histotrauma given complete important clue points for intraperitoneal bladder rupture. What will happen? Okay, you mute your mic. I'll go to the next candidate. Candidate number May09.
Hello.
Yeah.
I've been provided with the spot zoomed images of the magnification images of the.
Your voice. Try to hold your mic or the mobile clearly.
Yes, hello.
Yeah, you're audible. Go ahead.
Sir, it's a spot magnification image of the axial CT, post contrast CT focusing at the right kidney. It shows there is expansion of the. There is a well-defined lesion noted into the posterior aspect of the kidney, which causing expansion of the renal parenchyma. So it could be either a space occupying region, likely most commonly it can be a lymphoma, or apart from that, I would like to keep another possibility of the.
Wait, I'll give you this image. Now see this image, the same lesion and the same pathology.
The provided this virtually constructed images of the angio images of the right kidney shows there is a gush of the blush of the contrast going to the upper polar mass lesion. So
very good.
Angiomyolipoma.
Why angiomyolipoma? Angiomyolipoma, how does it appear in CT for you?
So that middle part hypertrophic part.
Probably small, but the whole thing is appearing like a homogeneously dense. It is not like heterogeneous thing. The small like FNH. What is the deal like of FNH for a central scar? That's it. It's a straightforward case of oncocytoma. Old examiners have this case. They have this blush. We're saying blush and all. Now, why do you think of angiomyolipoma? So it's a straightforward case of a oncocytoma. Do not make mistake for this. Sometimes DD you can think of in adenocarcinoma, something like that, because of central scar. Okay, so it is a straightforward case. What is the treatment for this?
Either resection can be done.
Correct. Surgical resection sparing the kidney. So I've given the key points, including treatment, what are the details, everything I've mentioned. Go through it when you get the PPT. Okay. Mute your mic. Candidate number May02. Candidate number May02. Quick.
Yes. I have been provided with the non-contrast axial CT and
Don't be in a hurry. This is not a non-contrast. This is a contrast. You're seeing contrast, na?
Yeah.
So be 1 minute. Whenever you get the image, don't panic on anything. Give a pause, take a breath, and see the image, and then start.
Yes.
So by that time, you can tell, okay, good morning, good afternoon, sir. I would like to present my case. You keep saying these words and see the image, so that you buy the time to read the image. Okay. Now tell me.
contrast axial image, CT axial image in the section of the kidney, and the intravenous urography.
Okay, correct.
I'm able to see the contrast excretion from the left kidney.
Very good.
However, the calcific foci and small in size of the right kidney is seen in the CT and on the intravenous urography.
Okay, right kidney is small in size, you tell. Correct. That is correct. You told small in size with calcification of the more commonly seen with the parenchymal calcifications. When you say calcification, be very careful. Whether it's in parenchyma, whether a urothelial calcification, or whether there's a calcification within the calyces, you have to be very careful. So you're saying a parenchymal calcification. Okay.
So
diagnosis.
Likely right putty kidney.
Okay, it's a putty kidney. In exam, you tell renal tuberculosis. Putty kidney is what we say for a named sign. Only if they ask for named sign for this disease, you tell putty kidney. Otherwise, you're diagnosed by right renal tuberculosis. Now tell me, which part of the ureter will be commonly affected in tuberculosis? Proximal, mid, or distal?
Proximal part of the...
Very good. Distal, if it's affected, which disease?
Schistosomiasis.
That's it. Mute your mic. Candidate number May 03.
Hello.
Yeah.
This is a virtually reconstructed angio images on the first one, and the second one is the catheter angiographic images.
Very good.
Just showing the single renal artery on the right side, which is showing tortuous and beaded appearance in its proximal and middle third.
Very good.
So based on this, my differential is going to be fibromuscular dysplasia.
Correct. That's the diagnosis. Tell me a DD for this.
CD can be
simple. Atherosclerotic disease. Atherosclerotic disease is the most common DD you have to always think. Complete calcific deposits over there. So that is the thing you need to think. Okay. So that is one. So other than this, how do you manage fibromuscular dysplasia treatment, or further what is to be done?
Sir, if the patient has hypertension and if there is then we can do a angioplasty.
Very good. Stenting, whatever. That is the goal, because based on the patient's symptoms, as a hypertension, whatever, that's it. So you have to know. Other things is like prerequisites. They'll ask like, what is the procedure for a renal angiogram, the catheter angiogram, how you're going to do. Sometimes they might ask whether in your institute you have got exposure, if it is in a short case. So this is how they kept the images. Okay. Can mute your mic, will not waste time. This is simple. I've given all the key points. Will not waste time for this discussion. Candidate number May 04. 1 second. Yeah. This is for candidate number May 04. Quick. Are you there?
Yes, sir.
Very good. What are the images given to you?
So I've been provided with axial contrast images of the abdomen at the level of the kidneys. There's a well-defined multi-cystic lesion arising from the left kidney, which is showing minimal enhancement of the walls of the septae. And there's no evidence. There's a slight indentation on the anterior aspect of the left kidney.
Very good.
The renal region appears normal. There's no evidence of fat stranding. The vessels appear normal. They're not displaced or involved.
Okay.
So, depending this, my likely diagnosis for this case would be a multicystic nephroma.
Correct. That's the correct answer. What is the DD for this?
So it could be multiple cysts can also be seen in adult polycystic kidney disease.
Probably, but you're not seeing here, na? Don't sell polycystic kidney disease, because you see, right kidney is fine, rest of left kidney is only one lesion, a solid lesion with multiple cystic areas noted within. Don't tell me polycystic kidney disease for this as a first DD. So, what are the other DD you want to think? We had discussed hydrated. Hydrated also can be a DD for this. Okay.
Yes, sir.
That is hydrated. Yes, other than hydrated, what else? A cystic venous tumor, cystic RCC. That also can be DD for this. Okay.
Okay, sir.
So given the key points, when you get the PPT, just go to the key points. Whatever things have written, description,
okay, sir.
All those things again. Mute your mic. Candidate number May 05. Simple case. First one is what image? This is the first image. This is the second image. What is the first image?
Non-contrast axial CT image.
And this is?
Post-contrast images.
Okay. Describe the pathology for me. Don't tell a diagnosis. Tell me the diagnosis. I mean, description. I want you to read the images. CT image, quick.
Hypodense, wedge-shaped hypodense area in the right kidney posteriorly.
Okay. Right or left? This is a right kidney. Na? This is a right kidney. This is a left kidney. First, tell this image description. What is happening here?
It also shows hypodense areas in the left kidney. Post-contrast also shows the same. No evidence of enhancement.
Okay.
And similar lesion also noted in the right kidney.
Okay. Given for me also, I would have told this as a non-contrast CT only, but they're given this description. They're given as a arterial phase CT or something like that. They're given. This is also CT. It's not a classical, but they are given this as a contrast CT. So if this is a contrast, what is happening? This wide difference is there. What is the sign?
Then striated nephrogram.
Rather than striated, like a rim nephrogram. Only the peripheral rim is only enhancing. The central is not enhancing, correct? So what is the cause for this type of enhancement? Here you are not seeing enhancement, in the delayed it is seen. So which condition you see like this?
Pyelonephritis.
Pyelonephritis is one of the commonest you can think, yes. Other than pyelonephritis, which other condition?
Vascular avulsion injury.
Okay, rather vascular avulsion injury, think of the common renal infarction or some thrombosis of the renal small segmental artery can give appearance like this. This is not a classical case. They keep these type of case only for OSCE. This will never be kept as a short case or a long case. This will be kept as a spot or a OSCE, and then they'll ask you, patient came with a history of pain abdomen, then post-contrast CT showed these things. What is the diagnosis? What is the DD? Diagnosis, as you can write, if you don't know, you can write pyelonephritis and then give DD as a infarction. Okay? So how would this be managed? How exactly are you going to manage renal infarction further? It can be even infection or infiltrating neoplastic lymphoma or TCC also.
Check for the cause by doing renal angio.
Correct. That's the correct answer. You have to do a renal angio. Look, is there any vascular thrombosis? Yes or no. And then you need to treat accordingly. Okay. This case was a case just for renal infarction. Candidate number ME06. I think I'll come back to you later on for this because similar case you had seen. I'll come to candidate number ME08.
Yes, sir. Provided are axial contrast CT images where I can see a large left perinephric, maybe hyperdense soft tissue content could represent hematoma.
Soft tissue density lesion. Wait, don't directly go to hematoma. It is a soft tissue density lesion. Okay.
Yes, sir.
It is a perinephric soft tissue density lesion. So on post contrast, it is you can see the soft tissue lesion is invading the renal parenchyma also. Yes or no? Part of the calyces, ureter, sinus, everything, it is completely invading. So what is the diagnosis first?
First I'll consider lymphoma.
Correct. Until unless they give a history of trauma or RTA or something like that, you will never tell perinephric hematoma, something like this. Complaints of pain or complaints come for evaluation, you will always tell perinephric lymphoma. If they give history of trauma, all this, then you look for the vessels and then for hematoma. Perinephric lymphoma, what are the management? What is the further management?
Chemotherapy.
Correct. Or chemotherapy is the correct answer. Correct. That is very, very important. Just don't write medicinal management, conservative management, all those things when they ask something about treatment. You don't have to know the exact chemotherapy drugs. At least chemotherapy you have to know. That is the correct answer. So it will encase the renal vessels, renal lymphoma, and it can come from direct extension of the retroperitoneal lymphadenopathy. Okay.
Yes, sir.
It's a simple case, not high-fi things. We'll come to the. You answer this case.
This is the MR prostate image of T2 image and multiplanar T2 images.
Correct. So, T2 circle on all the three planes are given. So where is the pathology?
In the transition zone of the prostate gland, I can see a well-defined nodular lesion, which is indenting the bladder base and protruding into the bladder. So
okay, it's a heterogeneous lesion noted in the which lobe, like median lobe you want to add. You tell specifically where lesion you're seeing in the prostate gland. You have to be specific when you describe the lesion.
It's a median lobe.
Okay. What is the diagnosis?
I'll consider benign prostatic BPH nodule.
Okay, why it is a benign? Why not a malignant?
The T2 signal, I feel there is an encapsulated nodule.
Very good. And mainly it has a hyperintense peripheral zone of the gland. You can see this hyperintense peripheral zone of the gland.
Peripheral zone is normal, yes, sir.
Correct. So malignant lesion usually affect the periphery, whereas the benign will more commonly in the center. Prostate, they are very fond. I want you to answer this case also. Now see this case. You've given the arrow mark. See for those things.
In the right lateral peripheral zone, I can see there is a T2 hypointense lesion, which on ADC shows low signal, so restricted diffusion, and
very good.
Like, and even in the coronal fat suppressor, I can see the lesion is hypointense on the T2 fat suppressor image. So, wedge-shaped lesion with the restricted diffusion, I'll consider a malignant lesion. So, PIRADS 4 could be the like based on the size less than 1.5 centimeter and also no invasion, I'll consider maybe a PIRADS 4 lesion.
I've given the important clues and important things for a CA prostate, T1, T2, T points, everything given, including the PIRADS 2.1 version. What are the things you need to know? You don't have to know in detail about these things, don't by heart. Just go to the clue important points. Even exam sometimes they'll be confused. So answer coolly and calmly if you get a prostate case. It all depends on the place or examination center where you get a case. Every examiner will have one prostate case because prostate malignancy is very common. So it is not like how it is common like US or UK. India also it is seen, but not so much aggressively. Only in the cosmopolitan places you see, not in the tier 2 cities. So if they ask about PIRADS 2.1, what is the staging, how it is done, important clues, how is the management, you have to know. That is why I've kept both benign and malignant. Okay, I hope this is clear. And the scoring also I've kept it. You can go through this. Okay, mute your mic. Candidate number May 09. You have answered now. I'll just come back to then May 06. You want to answer? You can answer this. It's a simple case. This is a spotter. This is like a spotter because I was not when I was preparing. I kept this. That's why. So name of this calculus. Others now when you're seeing now, you can just put it in the chat box. If you want to answer, you can keep answering. So it's a self-evaluation. You get to know how many got correct or wrong. If you don't like to put in chat box, take a book and write the answer and evaluate when others are answering whether you got it or not. Okay. Answer is a simple. It's a Jackstone calculus. Okay. You should be knowing some entities. Candidate number May 09. Quick. You have given the history. Yeah. May 09.
Provided. Hello, sir.
Yeah. Go ahead. This is ultrasound image. Tell me diagnosis. Don't waste time. Diagnosis. So the clue is.
The patient is on a bipolar mood disorder medication. So it could be a nephrocalcinosis. It can be a cortical nephrocalcinosis. That
is almost correct. But which drug, if they will give for bipolar mood disorder, that is a diagnosis.
Lithium.
Correct. This is a lithium toxicity. So you should know, be aware this is a lithium toxicity, how it will appear. Okay. So this is a simple case. You only answer quickly, not waste time. So we'll go for chest imaging next. Straightforward, simple case. Quick. It's a trauma case.
So
trauma.
Images shows the
diagnosis. That's it.
It's a subcutaneous emphysema and the perinephric tear. So that could be a.
It's a simple renal laceration. This is a trauma case. It's a renal laceration. It is nothing much. So it's a laceration right kidney. I've given the important line diagram to make you remember the laceration of 1, 2, 3, including subcapsular, superficial, deep, more than 1 centimeter, how it happens. Okay. You can mute your mic. Candidate number May 07. What's the study name?
Okay, sir. It's a MCU, micturating cystourethrogram or voiding cystourethrogram.
Okay. Diagnosis?
By right-sided, maybe grade 4 or 5 asecuretic reflex.
So they'll not ask in detail about grading and all, but at least you should be knowing what are the grades from grade 1 to grade 5. Okay, mute your mic. Candidate number May 07. In case I'm forgetting someone to call, you can always raise your hand. I would call you. Candidate number May 07. What's the diagnosis? Only diagnosis. Do not waste time.
ADPKCD, sir. Sorry, autosomal.
No. Don't be see the calyces now. What has happened to calyces? Upper pulse calyx is there, mid calyx, lower is not seen. Okay. It's a phantom calyx. Which condition is your phantom calyx?
Tuberculosis.
That's it. So that's right. One more case for you. Answer this. Study name. What's the diagnosis?
Sir, retrograde urethropathy.
Very good. Diagnosis?
Sir, urethral injury.
Correct. Simple straight urethral injury. You don't have to know the types, varieties and all. Urethral rupture, you have to know. Mute your mic. Candidate number ME01. We have discussed this many times today. Are you there? ME01, are you there? We will not waste time. Yeah. What's the diagnosis?
Sir, your voice is not audible.
Am I audible or not? Hello? Am I audible? Okay. Okay, ME06. If you want to answer, you can answer.
Yes, sir. So there is extravasation of collection of the contrast.
No. This is not a contrast study. No. This is not a contrast study at all. Okay. You can see vessels. Nothing is there. This is a calcification of the testis. Okay. So condition. Okay. Which condition you see calcification of testis?
Testicular trauma.
No, trauma. Why you see a calcification? It is an infective etiology. Which are the commonest infective? Old hematoma, yes, accepted, but it will not be like a linear peripheral calcification of testis like this. Okay, so you're seeing a calcification of the kidney. You all means for the testis. Always think about the infective etiology first. See, we discussed about parenchymal calcification of the kidney, tuberculosis, ureteral calcification, schistosomiasis, bladder calcification will be again schistosomiasis. Sometimes even tuberculosis also can cause. So now you're seeing a testicular calcification. Which condition will cause testicular calcification? Tell me cause for testicular microsis, tuberculosis. But this is not like looking like a microethiasis. It's looking like complete peripheral calcification. We discussed one case, cystic nephroma. What was the DD for cystic nephroma?
Hydrated cyst.
Correct. This is a case of hydrated. Very rarely we see renal testicular hydrated. The cycle you have to know. Sometimes they'd ask whether human is definitely host, animal is definitely host, from where exactly we get dehydrated, what is the scolex, how does the infection occur to us, they ask.
Okay,
you have to answer this case. Sorry. Are you there? ME06?
Sir, I have been provided with the intravenous urogram.
Very good.
There is a medial, there is normal opacification expression of the contrast bilaterally.
Very good. Correctly said.
Medial this deviation of the right ureter is seen.
Yeah, this is okay. This deviation, don't worry. This all things are normal. I wanted to only pick up this thing. Why is this one contrast like getting outpouched like this? What is the condition for outpouching contrast here?
Sir, parapelvic cyst or pelvic cyst.
Cyst will never enhance. Remember that. Cyst will never give contrast pooling within inside it.
Okay, sir.
Outpouching. Outpouching, what will go into outpouching? You see a bladder outpouching, what is it called as?
Diverticulum.
The same thing apply out. It is a calyceal diverticulum, which you need to know. Okay.
Okay.
So this is the last case. You need to answer quick. What is the calcification? Which organ calcification seeing over? It is a male or female? Tell me first.
Yes, sir. I think this is male.
Very good. It's a male patient. So which organ calcification you see?
Epididymal.
No. Why will epididymis no? Testis will be lower down still. So which other thing? I'll give you a CT image. Okay, don't worry. It's a vas deferens calcification. Okay. Even I have not seen. Only if you've seen, not forget this. Okay. Cause will be usually diabetes or a genital tuberculosis, schistosomiasis. It's an incidental finding. So you need to know about this vas deferens calcification. Mute your mic. Candidate number ME03.
Yes, sir.
Look, what is happening here? Study name, then your diagnosis.
Sir, I can say this is the intravenous urography.
Very good.
And
diagnosis, quick.
Medial deviation of
excellent. Perfect.
So retroperitoneal fibrosis.
There's middle deviation on both the sides. So it's a classical case of retroperitoneal fibrosis. Causes for retroperitoneal fibrosis, you need to know at least 2 to 3. Sometimes radiation or surgery, or some inflammatory disease, or sometimes pseudomonas abscess that will cause deviation of the ureter. Am I clear?
Yes.
The last case you answer quick.
Sir, there's a posterior urethral valve with dilatation of posterior urethra.
Correct.
And
this is a dilated posterior urethra. So this is a posturethral valve. Okay. This is the last case. This is a splinter name. I was not when I was preparing and just saw in the museum one of the case was kept like this. This is an artificial urinary sphincter. Even I was not knowing. Few examiners will have this type of cases. Will not know. So this is an artificial urinary sphincter. They might ask like a spotter, but not for asking nothing much in this. So you should be aware of different types of things. A sphincter. Sometimes you even have a implants like implants for the male, like a penile implants, or you might have tubectomy rings, clips, all those things you have to know. Okay, that's it. You want a 5 minutes break, or you want me to start with this directly now? Quick, put in the chat box. Okay, we'll continue then. We'll not waste time. We're already running out of time. We'll go with the chest cases. We'll again start with the May 01 from the beginning. Okay,